Thank you for joining Continuous Learning with Bioguard. It is my pleasure to introduce our webinar speaker, Dr. Jingwen Luo. Dr. Luo received her DVM master degree and PhD candidate in clinical veterinary medicine from the Nanjing Agricultural University in China. Currently, she is a specialist at Veterinary Ophthalmology and owner of Boku Pet Hospital, providing specialty ophthalmic services for small animals. She is also serving as the tutor for master student at Nanjing Agricultural University. Today, Dr. Luo will present the clinical management and progression of several real-world cases, highlighting initial presentations, therapeutic interventions, and recovery outcomes. She will also examine how laboratory test results obtained during diagnosis and treatment contributed to confirming definitive diagnosis and guiding therapeutic adjustment, ultimately supporting the animal's recovery. We are excited to have Dr. Luo as the speaker for this webinar. Without further ado, let's welcome Dr. Luo.
Thank you, Robert. And let me share my screen first. Okay, hello everyone, and good evening. I'm Jingwen Luo, and today I'm going to walk you through typical cases of ophthalmic diseases in dogs and cats, the role of laboratory test results in supporting diagnosis and clinical management. First and foremost, I would like to extend my sincere gratitude to Bioguard Company for offering me this wonderful opportunity to connect, communicate, and learn from such a distinguished panel of veterinary peers. So, over the next few minutes, I will walk you through several clinical cases, one corneal case and 3 uveitis cases. I will also share practical diagnostic and treatment tips and go over key points we need to keep in mind in daily practice. Without further ado, let's get started with the first clinical case. Okay, the first case. This is a case of infectious keratitis in both eyes of a dog. Let's look at the pictures. These 2 photos were taken when the dog first visited our hospital. Just a quick reminder, OS stands for left eye. This is the left eye, and OD for the right eye. Now, let's look at this slide. It contains the basic information and medical history of our first case. This is a 12-year-old female spotted Bichon Frise. First, and as you can see in the photo, this is what her left eye looked like when she came to us. Here. Now let's go over her medical history. 1 month before her presentation, she underwent thermal keratoplasty and third eyelid flap at a previous hospital due to left eye corneal melting. After a 3-week hospitalization, the flap was removed and the dog was discharged from that hospital. 1 week before her presentation, corneal melting recurred in the left eye, and a corneal ulcer was detected by the owner in the right eye as well. The owner administered the eye drops prescribed by the previous hospital at home. 3 days after that, the patient's visual acuity deteriorated and the corneal symptoms worsened progressively. Upon presentation in our hospital, the dog had already suffered complete blindness. In the past few days, the decline in the visual acuity seemed to have also affected the patient's mental state and appetite, which makes sense here, since sudden blindness can be really stressful for animals. So that's the background of this case. Now let's get into our diagnostic workup for her. First, let's look at the basic ophthalmic examination results for this patient. We've organized them in this table. The OD, the right eye, and OS, the left eye, side by side. First, let's go through the reflexes. The malus reaction was absent in both eyes. No surprise, since she has blind. Palpebral reflex and corneal reflex, were present in both eyes, so the nerve pathways for eyelid movement were still working. For PLR, the papillary light reflex, let's break down the PLR results. For the right eye, this column, the right eye, we observed a diminished direct PLR. That means the pupil reacted weakly when we shined light directly on it. And no indirect PLR. That means the other pupil did not react when we tested the right eye. For the left eye, here, we could not observe any direct PLR at all. This is because we could not even see the pupil changes, likely due to severe corneal clouding. But the indirect PLR was also absent. Here, the right pupil did not react when we tested the left eye, and this is a key sign. It suggests the left eye's retina or optic nerve may have already been damaged. We also performed CPLR, that's colorimetric papillary light reflex, using red and blue light. Here too, only the right eye had diminished response, while the left eye showed no response. The dazzle reflex was present in the right eye, but absent in the left eye. This is another clue about the left eye's more severe damage. Now to key quantitative tests. STT, Schirmer-Till test. Both eyes were in the normal range, 20/21. So dry eye was not the issue here. IOP, intraocular pressure. This is a significant finding. Look at the right eye, it's 65. This was significantly elevated. And the left eye was 8. It's low. You know the normal range for dogs the IOP is 10 to 20 or 10 to 25 according to different company. But 65 here is significantly elevated. These results tell us there was more going on than just corneal problems, especially this high IOP in the right eye, which pointed to secondary glaucoma. Okay. Next, we'll dive into more specialized diagnostic tests. Now you see the slit-lamp examination. The slit-lamp findings for the right eye, OD, the right eye. You can see the two images of her right eye here. First, the corneal opacity and uneven thickness. The cornea looked cloudy, and you could also see that its surface was not smooth. Plus, the thickness varied across different areas. Second, we saw hypopyon. That was the build-up of white blood cells in the anterior chamber of this eye. You might notice the whitish area here. So that's very severe symptom. Now here the slit lamp findings for the left eye. You can see the images of her left eye here. What we observed here is quite critical. The left cornea was edematous and melting, with a droplet-like bulging appearance. This bulging is a major red flag. It meant the cornea was already severely swollen and actively dissolving. Corneal perforation could have happened at any time, especially just look at here, the grayish black area in the image. It already looked extremely thin, like it was on the verge of perforating. That's why acting fast with aggressive intervention is so critical for cases like this. Okay, next, let's look at the corneal fluorescence staining. The corneal fluorescence staining result revealed extensive corneal ulcers in both eyes, with the lesion involving more than 60% of the corneal surface in the left eye. Corneal fluorescence staining is the test that highlights damaged corneal tissue, corneal surface. So you can see the green stained area, meaning most of the cornea was damaged. Now let's move to the corneal cytology results. From the slides, we identified two key findings. One, neutrophil, this is a neutrophil, and bacteria. This confirmed an active bacterial infection driving the corneal damage. To ensure our treatment was targeted, we sent corneal swabs to Bioguard lab for bacterial culture and antimicrobial susceptibility testing. This would let us know exactly which medications were most effective against the specific bacteria present. Now, let's dive into the ophthalmic ultrasound examination findings. First, this one, the right eye. From the ultrasound, we could see two key details. One, there was a local corneal defect, and the thickness of this area was noticeably noticeably thinner. The iris, the other one, the iris was thicker than normal. Here, this told us the iris was swollen, likely from secondary inflammation due to the corneal issue. Now we turn to the left eye. The changes here were more severe. The cornea was significantly thickened, and its structure looked irregular, consistent with the active melting we observed. Secondly, the iris was not only swollen, it's also swollen. And here, locally adhered to the corneal endothelium. This synechia is a critical clue. It suggested the left eye may have had a corneal perforation at this site previously. Also, thirdly, we also saw local increased echo in the lens. This is a sign that a cataract had developed in that area, in this area of the lens. This ultrasound gave us a clear picture of how extensive the cornea and iris damage was. These issues were closely linked to the active infection. Now, let's talk about the hematological examination. We performed this to rule out systemic infection, immune disorders, and endocrine diseases associated with bilateral corneal lesions. First, CBC and biochemistry showed elevated CRP, hypercholesterolemia, and hypertriglyceridemia. Then the endocrine test, LDDST. LDDST is the low-dose dexamethasone suppression test, confirmed that the dog had Cushing syndrome. This is a critical connection to the eye issues when cortisol levels are high, as in Cushing's. It can slow down corneal healing and make the cornea more prone to melting. Exactly the severe tissue damage we were seeing in this case. So this underlying endocrine condition likely made the dog far more vulnerable to this aggressive corneal infection. These blood results helped us target not just the eye issues, but also the underlying systemic conditions that may have contributed to this severe infection. Now, let's wrap up the final diagnosis based on all the tests we had done. First, the left eye, a severe melting corneal ulcer. For the right eye, it was an infectious melting corneal ulcer complicated by secondary uveitis and secondary glaucoma. And finally, Cushing's syndrome was identified as a systemic comorbidity. It likely played a role in how quickly these bilateral ulcers progressed. This diagnosis allowed us to map out a treatment plan and targeted both the acute eye issues and the underlying systemic condition. So let's move to the treatment plan we initially considered. For severe cases like this, surgical intervention is usually the first line choice. Common procedures here would be things like conjunctival flap or corneal cross-linking techniques. But however, the owner refused anesthesia and surgery due to concerns about anesthetic risks. So we had to pivot to a medical management plan. Instead, since surgery wasn't an option, we moved forward with a conservative treatment. And let's break down what this included. First, oral medications. Meloxicam 0.1 milligram per kilogram once daily to reduce inflammation and manage pain. Amoxicillin clavulanate potassium 20 milligram per kilogram twice daily, plus pyridofluoxacin and doxycycline. Since we were still waiting for the antimicrobial susceptibility results, and given how urgent the infection was, we used a combination of antibiotics to broadly cover the bacteria we had identified. We also prescribed oral trilostane. This was to manage the underlying Cushing's syndrome. Then the topical eye drops, tropicamide, twice daily to keep the pupil dilated, which helps with the uveitis. Brinzolamide to control the secondary glaucoma. Chloramphenicol and neomycin sulfate 4 to 6 times daily. Additional topical antibiotics to target the corneal infection directly. Allergenic platelet-rich plasma, PRP, 6 to 8 times daily. This wasn't just for healing. Its protease inhibitors also helped fight the active corneal melting, blocking the enzymes that break down corneal tissue, which was critical for this case. 0.75% higher malonate acid, 4 to 6 times daily, which was to lubricate the eye and protect the damaged cornea. This multi-layered plan targeted the infection even before the AST result, and quelled inflammation, addressed the underlying Cushing's, and actively worked against the corneal melting. We just wanted to support corneal healing in every possible way. And now let's look at the update 2 days after treatment. The corneal infection did not appear to be effectively controlled. That's an ongoing challenge. Compared to the initial presentation, the corneal ulcer area had grown. The original 2 separate ulcers had fused into a larger lesion here. Plus, we could still see yellow inflammatory infiltrates around the ulcer edges. So that's an ongoing challenges. But there were some positive signs. Intraocular pressure had returned to normal, right eye 11, left eye 5. So the glaucoma we concerned had resolved. The right eye had regained weak vision. The dog was slightly more willing to move around at home, which was a small win for its sight. Thankfully, just as we were struggling to get the infection under control, we received the antimicrobial susceptibility test report from Bioguard lab. Now let's walk through the bacterial culture and AST results. First, the identified bacteria, it was Staphylococcus. This is a common bacterial pathogen in corneal infections, and it showed moderate growth. Looking at the susceptibility panel here, most antibiotics we initially used, like amoxicillin clavulanate and doxycycline, showed resistance or intermediate sensitivity. But vancomycin tested sensitive. So we adjusted the treatment plan right away based on these results. We started subconjunctival injections of vancomycin 0.15 milliliter per eye, every 1 eye, for 1 eye. Administered once weekly until the cornea healed. This delivered the antibiotic directly to the eye for stronger targeted action. And at the same time, we discontinued oral and topical antibiotics with demonstrated resistance here. Now let's check in on day 6 of treatment. First, the positive updates. Intraocular pressure was normal, but slightly low, right 10, left 6. The pressure maintained stable. So from this point on, we discontinued brinzolamide. The right eye had recovered partial vision. The dog had normal malus reaction. This is a clear sign, meaning its sight was improving. And a small amount of hypopyon remained. We can see from the picture here. So internal inflammation wasn't fully resolved yet. And the fluorescence staining from this picture, the fluorescence staining showed the ulcer area hadn't grown larger compared to our last check. So the lesion wasn't spreading. But there were subtle changes in the cornea itself. Please look at here. The cloudy area of the cornea had expanded. The region that previously had inflammatory infiltrates, the yellowish area, remember, had now turned into a white opaque zone. Even this, we kept the vancomycin plan in place and monitored how the cloudy area evolved. Okay, now let's look at the 14th day of treatment. If we look at the both eyes, we can see extensive new vascularization at the limbus. Here. This is actually a good thing. New blood vessels bring oxygen, nutrients, and healing factors to the damaged area. They are a clear sign the tissue was actively working to repair itself, even though the corneas still looked cloudy. This vascular growth was a promising step toward recovery. Okay, let's jump to the 21st day. First, here, on fluorescence staining, we could see the ulcer area was slowly shrinking compared to our early checks. While the pace was really gradual, it was a clear sign the lesion was healing. Most importantly, here, corneal neovascularization had grown into the ulcer area. Here, the fine red vessels in this photo. This is a huge milestone. It meant the body was delivering nutrients and healing factors directly to the damaged cornea. This slow but steady healing told us the targeted vancomycin plan and conservative treatment were finally moving the needle. Now, let's look at the 28th day of treatment. From the photos, you can see the entire corneal lesion was almost completely covered by corneal neovascularization. Those red vessels had spread across nearly the whole damaged area. And on the same day, fluorescent staining confirmed that the cornea of the right eye had healed. The left eye was still wrapping up its healing process. We could see some residual staining here. It's amazing to see how far we've come from large melting ulcers. This meant the worst of the infection and tissue damage was behind us. Now, let's check in on the 40th day of treatment. The corneas were in the scar healing phase, with opacity at the original ulcer site. This is totally normal. When the cornea heals from severe damage, it forms a scar to seal the tissue. This meant the acute phase of the condition was completely over. The corneas were stable, and we just needed to let the scar tissue mature. And let's wrap up with the 88th day of treatment. This was the long-term outcome of severe corneal melting. The corneas were fully healed here and here. But you can see from the photos, there were obvious scars and pigmentation remaining. It had been a long journey, but seeing both eyes in this final healing stage was really rewarding. In this case, it was the laboratory test results and that provided us with timely information, allowing us to make an accurate diagnosis, adjust the treatment medications promptly, and ultimately achieve the positive outcome of curing the condition. Therefore, it is highly necessary for our hospital to be equipped with an antimicrobial susceptibility testing analyzer. It can provide crucial support when we are in urgent need of identifying effective antibiotics. Now let's move on to the cases of uveitis. Case 1. Uveitis in a cat secondary to viral infection. First, the basic information. This is a 1-year-old male castrated British Shorthair. The photo you see here is his left eye at the time of consultation. You can already spot the red hemorrhagic fibrin membrane in the anterior chamber. This is a hallmark sign of severe uveitis. Okay, let's walk through this cat's clinical history. First, the eye-specific timeline. The left eye developed inflammation 1 week prior to presentation. Initially, the only signs were blepharospasm and epiphoral, followed by progressive mild corneal opacity. Hyphema was noted in the left eye just 1 day before presentation. So the eye signs progressed quickly over a week. Now, the general history. Behavior: lethargic at home, spent most of the time sleeping with little activity. Appetite: poor, very picky with food. Gastrointestinal symptom: recurrent diarrhea, showing intermittent improvement after treatment, but prone to relapse. This is key, the general history. This is key because uveitis rarely remains isolated. These systemic symptoms, the lethargy, the poor appetite, chronic diarrhea, told us this wasn't just an eye problem. Uveitis in cats often ties back to underlying causes. We needed to dig deeper to find the underlying trigger to treat effectively. So let's dive into the details. This is the basic physical examination. The key takeaway here are the elevated body temperature and underweight disease. These are clues reinforced that we were dealing with a systemic issue, not just an isolated eye problem. Let's move to the basic ophthalmic examination results. Here, the right eye OD, the right eye, was mostly normal. All reflexes, malus, PLR, palpebral, PLR, dazzle were intact. Tear production 19 was normal. IOP 24 was on the higher end, but not critical. Fluorescein staining negative. So no corneal ulcer. The left eye, here, the left eye was where we saw major changes. No malus reaction, no dazzle reflex, so vision was impaired. We could not assess PLR or CPLR because the hyphema and fibrin membrane made the pupil impossible to see. Remember the photo we saw earlier? Tear production 21 was normal, but IOP 11, it was lower compared to with that in the right eye. The low IOP here in the left eye is a textbook sign of uveitis, since inflammation reduces pressure in the eye. Let's look at the slit-lamp examination findings. Compare the two eyes. The right eye looked normal. The left eye told a different story. The slit-lamp confirmed what we suspected. There was hemorrhagic fibrinous exudation in the anterior chamber. Then let's take a look at the fundus photography findings. For the right eye, OD, the fundus looked normal. You can see the clear blood vessel pattern and optic disc in the photo. For the left eye, we could not see the fundus at all. This isn't surprising because the hemorrhagic fibrinous exudation we saw on the slit lamp was so dense, it blocked light from reaching the back of the eye. Next, let's look at the ophthalmic ultrasound results. Here, first the right eye. The eye structure looked clear with no abnormal echoes. For the left eye, we saw moderate echogenic material in the anterior chamber. Here, this lined up perfectly with the hemorrhagic fibrinous exudation we saw on slit lamp. And importantly, even though we could not see the left fundus with photography, the ultrasound told us there was no sign of retinal detachment. So the posterior eye structures, like the retina, were still in place, which was a positive update. Now let's dive into the systemic examination results. This tied the eye issues to a critical potential diagnosis. First, abdominal ultrasound findings. We saw mild enlargement of abdominal mesenteric lymph nodes. This is a sign that the body was mounting an immune response, likely to the same trigger causing the uveitis. Then the hematological tests, the blood work. Here, the Ag ratio, albumin to globulin ratio, was 0.27. That's way below the normal range, 0.8 to 1.5, way below that. Importantly, you need to know an Ag ratio less than 0.45 is a strong red flag for feline infectious peritonitis, FIP. This is one of the classic lab signs of this viral disease. Okay, CBC, moderate anemia, SAA, a serum amyloid A, 28.2. This inflammation marker was clearly elevated. The biochemistry and urinalysis showed no significant abnormalities, so the focus stayed on these inflammation or immune-related abnormalities. Putting these together, the low Ag ratio plus the systemic inflammation elevated SAA, enlarged lymph node, and the severe uveitis, putting this together, this all pointed strongly toward FIP as the underlying cause of these CATS symptoms. Now we get to the definitive diagnostic step. An anterior chamber paracentesis to collect the aqueous humor sample for PCR testing. The results showed feline coronavirus, FCOV, FELV, FIV were all positive. And most critically, the PCR detected FIPV gene mutations in the samples. Remember, FCOV only causes FIP when it mutates into FIPV. And findings that mutated gene in the eye's aqueous humor tied the uveitis directly to the FIP. So combined with the earlier clues, low AG ratio, systemic inflammation, severe uveitis, this PCR result confirmed the diagnosis, FIP-associated uveitis. And what was made worse by concurrent FELV, FIV infection, which FELV, FIV, they weaken the immune system. Okay, let's walk through the treatment plan we put in place for this FIP-associated uveitis. First, the core antiviral treatment, GS441524, 15 milligram per kilogram subcutaneous once daily for 3 months. Then oral medication, amoxicillin clavulanate potassium, 14 milligram per kilogram twice daily for 10 days to prevent secondary bacterial infection, immune polypeptide oral solution, long-term use to help boost the cat's weakened immune system, especially since it's FELV, FIV positive. Finally, topical eye drops, tropicamide twice daily, dilated the pupil to prevent painful pupil adhesion, 0.1% dexamethasone, reduced the severe inflammation in the anterior chamber, 0.4% HA, hyaluronic acid twice daily, lubricates and protect the cornea. This multi-layered plan addressed both the underlying cause and the eye-specific inflammation. Now, let's check in on the 10th day of treatment. First, the pupil was still partially covered by a thick fibrovascular membrane, but the Malus reaction of the left eye had returned to normal. That's a clear sign the left eye's visual function had improved. It's a great progress considering we could not assess vision at the start original presentation. This follow-up showed the treatment was working. Even though there was still some physical residue in the eye, the functional recovery told us the inflammation and the viral active were being controlled. Let's look at the 14th day of treatment. We can see the change in the photos that the thick fibrovascular membrane we saw on day 10 was gradually decreasing. The eye looked clearer and the membrane was less prominent. Let's look at the 35th day of treatment. The key updates here are twofold. First, we saw pigment deposits on the lens anterior capsule. This is a common leftover sign after intense uveitis. But crucially, the malus reaction remained normal, so the cat's visual function was still stable. Looking back at the diagnostic and treatment process, it was the PCR test results that finally confirmed the underlying cause. Only then could we develop an accurate treatment plan, one that saved this cat's life and preserved its vision. So this case also illustrates the importance of laboratory diagnostics in our clinical ophthalmology practice. Now, let's move on to our second uveitis case. This one involves a dog, and the cause is linked to Vector-Borne pathogen. First, let's look at the eye photos. These photos taken when the dog was first presented. The right eye, at first glance, it looks relatively normal. But if we look closely, we can see conjunctival hyperemia, the redness. And the left eye shows obvious changes. The cornea is cloudy and whitish. There are new blood vessels at the nimbus, and both the conjunctiva and scleral are clearly hyperemic. Okay, let's start with the basic information and history of this case. This is a 1-year-old male Guangxi native hound. Half a month prior to presentation, the dog presented with lethargy, anorexia, and fever at a previous hospital. At that time, examinations revealed hepatic injury and immune-mediated thrombocytopenia. Given the dog's history of a prior tick infestation, the previous hospital tested vector-borne pathogens, and PCR results confirmed this dog was concurrently infected with Ehrlichia and Anaplasma species. This test report was obtained by the previous hospital by sending samples to Bioguard lab. Then let's pick up the rest of the history. After the tick-borne pathogen diagnosis, treatment with doxycycline was initiated, and systemic symptoms resolved within several days. But then, ocular issues started. Initially, the right eye exhibited inflammation with ocular discharge. The owner administered levofloxacin eye drops, and the condition improved after 2 days of treatment. Shortly thereafter, the left eye developed similar signs. The same topical treatment was applied, but instead of improving, the ocular condition of the left eye progressively worsened. After reviewing the history and combining it with the dog's clinical signs, these clinical signs, we needed to address two key questions. One, what is the specific diagnosis of the dog's ocular symptoms? Two, is there a connection between these ocular disease and the systemic infection? So next, we needed to perform further examinations on this dog to clarify the ocular condition. Now let's look at the basic ophthalmic examination results. First, all the reflexes, malus, palpebral, PLR, both direct, indirect, CPLR, corneal, dazzle, all the reflex tests were positive in both eyes. That means the dog's basic ocular nerve function was intact. Then the quantitative tests, STT, 16, 23, both within normal range. IOP, 10, normal, but 6, lower than normal. Fluorescence staining, negative in both eyes. So no corneal ulcers here. The key takeaway here, the low IOP in the left eye confirmed our suspicion of uveitis. Next, let's look at the slit-lamp examination. The findings showed the right eye looked relatively normal under the slit lamp. But the left eye showed two key signs. One, significant thickening of the cornea. Two, numerous small keratic precipitates scattered on the corneal endothelium. These findings are classic indicators of active anterior uveitis. Now let's move to the fundus photography findings. The right eye had no obvious abnormalities. We can clearly see the retinal structure. The left eye showed a generally blurred and indistinct fundus. We can't make out any details. This blurriness was likely caused by the corneal edema. Now let's cover the ophthalmic ultrasound results. For the left eye, we saw thickening of the cornea. There was swelling of the iris ciliary body here, but also here in both eyes. And this swelling was more severe in the left eye. So the ultrasound helped pull all our earlier observations into focus. This wasn't just a left eye issue. Both eyes had anterior uveitis. It was just more severe in the left eye. Since uveitis often ties back to underlying causes, and when we paired this finding with the dog's history of Ehrlichia and Anaplasma infection, it confirmed the link. This bilateral uveitis was a direct result of the systemic tick-borne pathogens. And now let's go over the treatment plan we put in place. First, oral medications. Meloxicam Cushing for 10 days to reduce systemic and ocular inflammation. Doxycycline for 3 weeks. This was to fully clear the Ehrlichia and Anaplasma infection. Then topical eye drops. This targeted the ocular inflammation directly. Tropicamide twice daily to dilate the pupil and prevent painful iris adhesions. 0.5% sodium chloride solution 4 to 6 times daily to reduce corneal edema. 0.1% dexamethasone and diclofenac 4 times daily. These are strong anti-inflammatories to calm the uveitis in the eye. 0.4% hyaluronic acid twice daily to lubricate and protect the cornea. This combination addressed both the underlying infection and the eye-specific inflammation. And we saw earlier progress with the treatment. By the third day of treatment, the corneal edema of the left eye had already started to improve here. This quick response told us the anti-inflammatory drugs like dexamethasone were working to calm the eye's local inflammation. It's a promising sign that our plan was on the right track. By the 10th day of treatment, we saw a full recovery. The left eye had completely returned to normal. The key to managing this case was identifying the link between the uveitis and the Vector-Borne disease. And thankfully, the test results from the previous hospital served as the work of investigating the cause of the uveitis, allowing us to skip straight to targeted, precise treatment. This is why we were able to get the condition to improve so quickly in the end. Now let's move on to the final case of today, case 3, uveitis in a dog secondary to the neoplasm. These are the photos of both eyes taken when the dog first came in our hospital for consultation. You can see the distinctive reddish discoloration in both eyes. This is a classic sign of uveitis, which we'll dig into more as we go through the case. First, let's cover the basic information for this case. This is a 9-year-old female border collie. The key part of his history is the dog presented with sudden bilateral blindness on the day of presentation. But notably, her mental state, appetite, and defecation, urination remained normal, so the issue seemed isolated to her eyes at first glance. Now let's go through the basic physical examination findings. The weight, body temperature, mental status, mucous membrane color, respiratory rate, heart rate, all of these were basically normal, except the body temperature was slightly elevated. But we found 2 key abnormal signs. 1, subcutaneous masses were on the left chest wall. 2, bilateral mandibular, right inguinal and popliteal lymphadenopathy were noted. Here. So the issue seemed isolated to her eyes at first glance, but now these findings are important. This means there was underlying causes. Now let's look at the basic ophthalmic examination results. First, the Malus reaction was absent in both eyes. This lined up with her sudden blindness. Other reflexes, palpebral, corneal, dasal were normal. So the eye's basic nerve responses were intact, even if she couldn't see. All PLR tests, direct, indirect, and CPLR were diminished in both eyes. This told us there was damage to either the retina or the optic nerve. Quantitative tests, STT 26, 22, both normal. IOP 7, 8, lower than normal, which is a classic sign of uveitis, just like in our last case. Fluorescein staining was negative, so no corneal ulcers. The key takeaways here, her blindness was paired with low eye pressure here and weakened pupil reflex. These are clues that the issue went beyond just the surface eye inflammation. Next, the slit-lamp examination revealed red turbidity of the anterior chambers in both eyes. That red haze was blood mixed with inflammatory fluid. It's a common complication of severe uveitis. The inflammation can irritate blood vessels in the eye, causing them to leak blood into the anterior chamber. Now let's look at the ophthalmic ultrasound findings. It showed moderate swelling of the iris ciliary body in both eyes, here and here. And we could also spot an extra detail in the image of the right eye, this one, the right eye. There was mild thickening of the posterior wall. This pointed to swelling of the choroid and retina, which meant this wasn't just anterior uveitis. It was posterior uveitis too. So this dog had panuveitis, explaining why her symptoms were so severe. She blindness at the presentation. The inflammation was impacting both the front and back structures of the eye. Since we couldn't get a clear view of the retina with fundus photography, we used electroretinography, ERG, to test the retina's function. ERG revealed that bilateral retinal function was partially preserved. This is an important detail. It told us her blindness was unlikely to be caused by primary retinal degeneration. This is a condition where the retina breaks down on its own. Instead, the tissue was more likely tied to the widespread uveitis. Since we suspected the uveitis was tied to an underlying systemic issue, we ran a full systemic examination to look for clues. By chemical profile, she had hyperlipidemia and elevated LDH. LDH is a marker that can signal tissue damage or inflammation. CBC, her neutrophil percentage increased. CRP was 69.96. So this was a big red flag that her body was fighting with a widespread inflammation. Urinalysis, no significant abnormalities, so the tissue wasn't centered in the kidneys. All these results confirmed there was systemic inflammation going on, exactly what we'd suspected if the uveitis was secondary to a body-wide condition. Finally, the abdominal ultrasound examination gave us the key piece of the puzzle. It revealed several spleen-associated tumors. Here, this one, very, very big tumor associated to the spleen. Here, another one, a smaller one. And this was the lymph node. The spleen-associated tumor paired with the swollen lymph nodes we noted earlier strongly suggested this was a case of multicentric lymphoma. And this fits with what we know clinically. Lymphoma is actually the most common type of tumor that causes uveitis in dogs. All the clue we saw the systemic inflammation, high CRP, elevated neutrophils, the widespread uveitis, and her sudden blindness. All of these are common effects of lymphoma triggering body-wide inflammation, including in the eye. At this point, while we hadn't finalized the definitive diagnosis, all the evidence pointed toward lymphoma. To definitively confirm the type of tumor, we would have needed lab-based histopathology. Since this was a cancer-related issue, we referred the patient to a specialized internal medicine hospital for further diagnosis and targeted treatment. Even though we didn't follow up on this case long term, I want to share it with you to emphasize that we often think of eye issues as just eye problems. But as we have seen in the cases earlier, what shows up in the eye is often a clue to what's happening systemically. And that's where lab tests become game changers. They help us connect the dots between eye symptoms and their underlying causes, turning a vague inflammation into targeted, effective care. All right. That is all the content for today. I sincerely hope that today's sharing can bring you some inspiration and help. If anyone has questions, feel free to bring them up. Let's discuss them together. Okay, let me open the box. Where? Okay. Let me scan your questions. Oh. Oh, the first question I saw here, is for the first case, I always about your treatment plan. I see several antibiotics for eyes. My question is, are you using combination for local antibiotic? If yes, what do you suggest for combination? Does we need to give several minutes each antibiotic for eyes? Yes. Let's go back to the slide. Here. Here. I give them a combination for local antibiotics. Here I use the chloramphenicol together. Because when I gave these topical eye drops, I was still waiting for the AST result. So I do not know which one could work, but just according to my experience, I use chloramphenicol as the first line, most time combined with neomycin, and also I will use chloramphenicol combined with levofloxacin or some cephalosporin medicine, just according to my experience, and also the product available by hand. Can you share how do you perform weekly subconjunctival antibiotics injection as it with local anesthesia alone? Oh, yes, we need to use the local anesthesia medicine first. After that, we do the subconjunctival injection. For the dog melting corneal case, in the end, what causes of the pigmentation and will it be disappear after that? And the dog still able to see after fully recovered? The pigmentation is a normal leftover sign. Okay. Until now, we cannot find a very effective way to diminish the pigmentation after they recovered from a very serious corneal damage. But you can try to use cyclosporin or tacrolimus. Just sometime, in some case, they will diminish, disappear a little, but most time that with no infection. And of course, it will infect the visual function. But compared the corneal serious damage, the scar, that's okay. We can accept the scar. Uveitis associated with mixed hemoprotozoan disease I had encountered, but it did not show any response to topical steroid back at my Mediatic, but it recovered beautifully when we changed to oral prednisolone. Yes, sometimes the oral medicine, the systemic medicine, prednisolone or other steroid, will work better, more effective than the eye drops. Because uveitis is the inflammation of iris and choroid ciliary body that have more strong relationship with circulation. So we give them the systemic steroid. Most time, the systemic steroid will work better, will more effective. How much sample do you need for aqueous humor analysis? You mean we do the paracentesis to collect the aqueous humor? Normally, that according to the lab, they need at least 0.2 milliliter. But normally, we take 0.6 because smaller than 0.6 milliliter will cause less damage than larger volume to the eye. Just a clarification for K3. Didn't the posterior thickening also showing in the left eye? Yes, and let me pick up the slide here. Yes. Here we do see mild thickening of the posterior wall of the right eye, but we cannot see the thickening of the left eye. But sometimes, the posterior wall, we check the posterior wall from the ultrasound is difficult. It's not effective detection. Sometimes it's very minus, very slightly edema, but we could not detect them from the ultrasound. But we can detect them from the fundus photography. So we combined these two methods together. We do the fundus photography first, and then we do the ultrasound. from two different methods to elevate elevate the fundus. For third uveitis case, you are using dexamethasone and diclofenac concurrently. Yes, and every topical. Here I pick this slide as an example. Every topical eye drop, I use tropicamide, then the chloride solution. I will give them 5 to 10 minutes apart. So here the dexamethasone and the diclofenac, I give them 10 minutes apart. If diagnostic tests are not available, how we diagnose? Well, you mean this one, the neoplasm? I don't know exactly what's your question. I want to ask for the first case, how to administer 3 antibiotics orally in the first case. How to orally antibiotics. Okay, let's go to the slides. This one. We give the oral medication, just this amoxicillin clavulanate twice daily, and pyridofluoxacin doxycycline once daily. You can give them together or half an hour apart. That's okay. Not difficult for the owner. How do you do eye ultrasound? Is the gel direct to the eye? How do you clean it after? How do I do the ultrasound? I will use the topical anesthesia first. After that, I use the gel. Put the gel on the probe and then directly touch the eye. After that, I will use large amount of saline to clean the surface of the eye. Can we give dexamethasone in cornea also in cat? For the topical dexamethasone, we definitely could not give this medicine to the surface, to the corneal surface, and we'd better do not give dexamethasone systemically. Even you give dexamethasone systemically, I mean oral or injection or other method, that also have bad infection on the corneal healing. How do you administer all eye drops for every eye condition? Does different drops have an effect to other drops when administered simultaneously? Just as I said, I will give different eye drops 5 to 10 minutes apart. Sometimes, maybe from the theoretical, different eye jobs will have affection with each other. I will apart them for a long time. Could we use genta-DEXA eye jobs? Genta-DEXA eye jobs you mean the gentamicin and dexamethasone combined is a product. I know that there is a product that include this. When you encounter the uveitis cases, of course, before you use this eye drop, you just need to make sure the corneal surface is normal, there's no ulcer, corneal ulcer. So then you can use these eye drops to control the inflammation. Can I use platelet-rich plasma in all cases? I only use platelet-rich plasma PRP in corneal ulceration, or sometimes the dry eye, not in all cases. If you want, you can. But I think we need to make the every prescribed medicine meaningful. I'm interested in the ERG test for the last case. What type of ERG is appropriate for this case? Could you explain further? Actually, in the third uveitis case, I just want to confirm the retinal function. So here I use the 3-step short. I just use a very short protocol. If you want to know the whole function, I mean the photopia, the day-night or the daytime and the nighttime, you need to use the 5 steps protocol, the long protocol. So here, I just want to know the function. Is there any preserved function? So I use a very short protocol. I see most of the eye causes you use of tropicamide. Is it all the eye cases can be used of tropicamide? Any contraindication of that? I only use tropicamide for the uveitis cases, not the even though the first corneal case, I also use tropicamide, but that's because there was inflammation. The uvei also there was a secondary uveitis there. Well, here, the diagnosis. Why did I use the tropicamide here? Because the right eye here, secondary uveitis, you only use tropicamide for the uveitis. What is the eye drop suggestion for anterior and posterior lens laxation if conservative treatment is preferred? Anterior laxation? The first one, anterior lens laxation. If you encounter an anterior lens laxation, the first medicine you use should be the mydriasis. You need to dilate the pupil, then let the lens have the chance to go back to the posterior of the eye. After that, after the lens go back to the posterior of the eye, you need the meiosis medicine to contract the pupil, keep the lens back inside in the eye. So for the posterior lens relaxation, we use latanoprost to contrast the pupil, make the pupil smaller than normal, and prevent the lens go in anteriorly.
Sorry for interrupting here. Due to time constraints, we will conclude the webinar at this point. Any unanswered questions will be forwarded to Dr. Luo, who can provide her responses via email. And our heartfelt thanks to Dr. Luo for the outstanding lecture and to all of you for joining us today. We are excited to welcome you again at our upcoming webinar. And thank you and good night.
Thank you. And goodbye, everyone.